CEO, NCI, Kesho representative, Ken co-chair and board members, Dr. Bo representing the DG, Ms. Phoebe, the executive director of KENCO, warriors, cancer survivors, caregivers, all protocols observed. Good afternoon.
Good afternoon.
Yes, thank you so much. It is indeed a privilege for me to be here to join you in this gathering. We, as the Ministry of Health, we are here to interact and have meaningful engagement with you, to understand what you're going through and see how we can ultimately improve social health authority in Kenya. As you know, we are a people-centered ministry. Our goal, our vision is to have a people-centered approach. So even for cancer, you as the cancer survivors give us the critical information that we need in order to improve the services. And so we don't take it for granted, and I hope, Dr. Nelly, this will be a first of many interactions. You know, at times we may sit up there in the national office and forget what's happening on the ground. And when I listen to your stories, indeed I'm touched. We have documented everything, and we will definitely come up with interventions to address all the concerns. And so maybe just to inform you, UHC, Universal Health Coverage, our sister has clearly said PRISCA, it's about affordable, accessible quality of care. When you look at the NHIF model, it looked mostly at the employed. They were the ones who were benefiting, okay? And it was really restricted to a certain proportion of Kenyans. But now we are moving to universality. How do we ensure that there is health care for each Kenyan at every region, at every corner? And I know even one of our sisters had talked about, staying in the mashinani and how can she access care. That is the current situation. And coming from the medical profession, I have seen it, where a woman comes and you're telling her surgical intervention is 200,000. Where does she start? And ultimately, let us remember that the donor fund is dwindling. We cannot rely on the donors. Today, as you can see, the elections are going on in the US. And those, we cannot just be there waiting to hear what's coming up. Are they going to donate? Are they going to contribute to HIV treatment, malaria, diarrhea? We as a country need to be self-sufficient. We should stand on our feet and ensure that we are able to take care of health matters as a country. And that is actually what UHC looks into. So it looks at care for the poor or the financially constrained and the very rich, all contributing to one pot. And those who cannot, that's the ones we are calling indigents, then we will also support them free of charge. It is looking at everyone. The people who have cancer, the people who have HIV, etc., all contributing to one pot. Because ultimately, we need to be self-sufficient. The donor fund is dwindling. We need to stand on our feet as a country and care for the sick in our country. And this was actually the vision of UHC. When we are looking at the health financing component, you will also notice that there are different areas we look to. There is the high burden diseases, like in children, they have coughs, diarrhea, we have malaria burden. We have women who are giving birth. We have what we call the catastrophic expenditure diseases, like now renal disease. They need to go for dialysis, chemotherapy also. So people can use a lot of money to get these services. So you can see the burden of disease is high in certain areas. People are dying in others. People are spending a lot of money in other areas. And yet we have a tight fiscal space following the financial bill. So meaning that the money that was given as we transition, it wasn't enough to cater for all these conditions. And so for us, we started with the key priority diseases. even as we build up to improve the health insurance. So what am I saying? These are the early stages. Just like a small baby who is, now we are 30 days or 31 days old, we don't expect the child to run a marathon or a sprint. But we hold that baby and patiently wait, yeah? Give them the right food, encourage them, and gradually they will grow. And that's why we are saying, let's not throw away a good thing. This social health insurance will cover every Kenyan. It's universal. It looks into quality. And there's a lot that we are doing as a ministry to ensure that we will offer quality care services to Kenyans. And so let us embrace it and let us be patient. We take note of the teething problems or the transition challenges that you have faced, and indeed we will take into action to ensure that you're able to access these very services that we are talking about. And so cancer remains a significant health challenge in Kenya, but we are proud to share that we are making considerable strides to support the patients at every stage of this journey, from the prevention up to the recovery. Cancer continues to pose a serious health challenge in Kenya. As we know, it's a leading cause of illness and death, and we take note, and that is why it was a high priority, and that is why this will be one of the many, many meetings we will have to ensure we're improving the quality for cancer prevention up to rehabilitation and recovery. So while we were discussing out there with the colleagues, one of them told me an interesting thing, that in MTRH a study was done, and on this study they found that after patients were diagnosed with cancer, only 25% could start treatment and only 50% would complete. And so that is why we are looking at UHC. How do we have early detection? How do we ensure that we onboard as many cancer patients as possible? And how do we ensure that they go through the whole spectrum of management, rehabilitation, recovery, etc.? There may be challenges previously with the diagnosis, but as has been said clearly, that our focus again is on screening and early diagnosis. We have expanded screening for breast cancer, cervical, prostate, and colorectal. They are accessible from level 2 up to level 6 in Kenya, so that we can ensure that we are having early detection. And with early detection, we know that the survival is longer, the quality of life is better, and the financial benefits are better. You will not spend so much money. And that's why you will see that there is really a lot of focus in this ministry on early detection. For NHIF, it was mostly management. So once one has been diagnosed, and before you get all those screening done, and before you start medication, a lot of time has lapsed and the disease has spread. But we're trying to break that by ensuring that we have early screening and detection. Again, this one would help for better outcomes and also for better quality of life. And you will see that that is why our focus is on the primary healthcare level. We have a primary healthcare fund to ensure that people are accessing. And as cancer survivors, I hope that you will encourage more and more Kenyans to go for screening early. This one will be accessible at primary healthcare level. Upon registration, one can access the services free of charge. Again, for diagnosis and testing, accurate diagnosis we know is the first step towards effective treatment, and we are now covering critical diagnostic services, including the cytology, histology, immunohistochemistry, which is making it easier and more affordable for patients to receive clear diagnosis. This was not previously covered by NHIF, and if it was limited. We are bridging the gap with social health insurance fund and the social health authority. So again, a brilliant progression on that. For imaging and screening, access to advanced imaging like X-ray, bone scans, ultrasound, CT scans, MRI, and PET scans are really crucial. And again, these are covered under the Social Health Insurance Fund. What I would like to inform you, dear colleagues, because I have had two colleagues also concerned that they had not received their PET scans. As you know, during the first week of transition, we had a lot of challenges. The thing is, we were rolling out something nationwide. And so before all the facilities could be contracted, before people could be able to have a seamless access to services, we had a bit of challenges. But now I can assure you, when you go to KUTRH, you will get your PET scan, you will get your imaging services there under the Social Health Authority. So for radiotherapy coverage, for patients requiring radiotherapy, we are now covering all sessions needed for a complete course of treatment, rather than a limited number that was covered under NHIF. This means that patients have a peace of mind knowing they can complete their radiotherapy without interruption. We take note of the systemic treatment support that was extensive with the NHIF. And we want to tell you that our oncology package includes the essential therapies, including chemotherapy, targeted, and immunotherapy. I have taken this down, the amount, and we will work as a team to see how we can expand. We were actually engaging with the colleagues, and we were thinking of even strengthening the access programs, advocating for reduced taxation, and then as well as thinking of bulk procurement among others. And what I have tasked the team to do is come up with interventions that we can have, so that we can have reduced cost for systemic treatment or other treatments for cancer patients.